morning and welcome everybody. Today I'm introducing Dr. Karen Mostert. She's a chemical pathologist with 24 years of pathology experience. She obtained her MBCHB degree in 1990 from the University of Pretoria and her FC Path Chem Path degree from the Colleges of Medicine of South Africa in 1998. She joined Vermaak and Partners Laboratory in the year 2000 and Pathcare in 2016. She has a keen interest in laboratory quality management, point-of-care testing, and utilization of laboratory data to optimize value-based care. Special clinical interests include markers of myocardial injury and endocrinology. Thank you so much.
Thank you, Dr. Godina. Good morning, everybody. Today I want to talk about immunoassay interference and the diagnostic dilemma that it might cause. So thinking about immunoassays, it's widely used in the clinical laboratories. It started off with the insulin assay in 1977, and since then it has evolved considerably. It's a sensitive and a specific technique that can detect up to picomolar concentrations using antigen-antibody reactions without the need of prior extraction, so a very easy method. But because of the complexities of the antigen-antibody interaction occurring in a complex matrix, several interferences have been identified. So looking at the case study, this is a cumulative report of thyroid functions of a 31-year-old female patient. She complained of fatigue in August 2020. She was started on thyroxine, 100 micrograms per day, based on a high TSH and symptoms. So her baseline thyroid functions with a free T4 of 15.2, TSH of 30.3. When she followed up 21st of October, the thyroxine dose was raised to 150 micrograms per day based on the TSH that remained high. And the slightly raised T4 was ascribed to taking thyroxine on the day of sampling. When the patient followed up in February of 2021, the TSH remained high. And at this point, the patient reported symptoms related to hyperthyroidism. The doctor was still not happy with the TSH that did not come down at this stage, and he treated her with thyroxine and added tertroxin. With follow-up in April 2021, this patient had symptoms of overt hyperthyroidism, with persistently raised TSH unexplained, and the doctor considered analytical interference at this point. So to understand analytical interference, we need to get an idea of the design of our immunoassay methods, and there are basically two big groups, the competitive group and the non-competitive group of assays. So the competitive assays will measure the smaller hormones, for example, free T4, vitamin D. And in this case, the analytic sample competes with a signaled labeled antigen for limited quantities of capture antibody in this reagent mix. After a washing step, all the unbound analyte and signal labeled antigen is removed. The bound signal is produced and the analyte concentration in the sample is inversely correlated with the generated signal. So that's a competitive assay. Looking at the non-competitive assay, that is the way that we measure TSH. And in this case, the capture antibody is fixed on the solid phase. The analyte in the sample and the labeled detection antibody are added. The two antibodies recognize different epitopes on the analyte and it forms a sandwich. And after a washing step, the bound detection antibody produces a signal and the analyte concentration is directly correlated with the generated signal. So as I say, it's TSH that we measure this way, also PTH, thyroglobulin, insulin, C-peptide, for example. Just some added information. Some of the methods would add an extra component to attach antibodies to the solid particle, so that blue antibody attached to the blue particle. And in this case, streptavidin and biotin is used. It forms a strong, highly specific bond with each other, and it is often used in immunoassay reactions as biotin is a small molecule that can attach very easily to a variety of targets, including antibodies. So the biotin streptavidin principle. I'm not going to go into too much detail into this table, but just to give you an idea of the immunoassay platforms that are used in South Africa. So the bigger labs, the NHLS, will all be using some form or the other of these platforms, the Abbott, Roche, Siemens, and Beckman. So if we look at the principle, you can see that the Abbott and the Siemens Advia method uses acridinium-labeled detection, not biotin streptavidin, while the other methods will all use biotin streptavidin binding with a ruthenium-labeled detection. Looking at the antibodies that are used with these methods, the TSH methods are all non-competitive using the sandwich assay, and they all rely on mouse antibodies. While the free T4, it's the competitive design that is used. The Abbott and the Roche will use sheep antibody, while the Siemens use rabbit, and the Beckman method use mouse antibodies. So looking at the different categories of interference, which I will discuss further, we are looking at heterophile antibodies, and one needs to remember that this includes rheumatoid factor. We're looking at human anti-animal antibodies, human anti-mouse antibodies, biotin interference, biotin and streptavidin antibodies, macrohormones, high-dose hook effect, ruthenium antibodies, and then other autoantibodies, for example, those that we see against thyroglobulin and insulin. So starting off with heterophile antibodies, the population incidence determined in 2013 it's quite variable. You can see from 0.2 up to 15%. And it will depend on the type of population that you are actually researching. So heterophile antibodies are endogenous antibodies that can bind to assay antibodies. It is produced without exposure or an unknown exposure to specific immunogens. These antibodies have low avidity, but they react across multiple species with the ability to bind to multiple antigens. And it can interfere with both types of our immunoassays. The non-competitive or the sandwich assay is more common. The heterophile antibodies can be of the IgG, IgM, or IgA isotype. And most of the time it would bind to the FC region of the assay antibodies, but it can bind to other parts of the assay antibodies as well. So rheumatoid factor is classified as a subtype, as we have already noted. So in this slide, just more about rheumatoid factor. We know that it is present in about 70% of patients with rheumatoid arthritis. It is defined as autoantibodies reactive with the FC part of human IgG. It can also react with different species IgG with variable affinity. And it was originally described as the IgGM subunit, but it can occur in any of the subclasses, IgG or IgA, and then most commonly IgM. So while most assays are optimized to eliminate the interference by rheumatoid factor, interference may still occur at very high concentrations. Just to give you an idea of how the heterophile antibodies will interfere, this is our slide with a competitive assay, for example, how we measure free T4. And there are two possible mechanisms. In the first place, the interfering antibody binds to the capture antibody, preventing the binding of measured molecules to the captured antibody. So you will get false positive results. The second scenario, the interfering antibody binds to the measured molecule or the labeled antigen, and it prevents binding to the capture antibody with also a false positive result. Looking at our sandwich assays or the non-competitive method, the way we measure TSH, there are three possible mechanisms. The first place, the interfering antibody forms a bridge between the capture and the labeled antibody, and you will get a false positive result. In the second case, the interfering antibody, again, the FAB part of the capture antibody, will prevent binding of the measured molecule in the patient's sample, and it will give you a false negative result. In the third scenario, the interfering antibody binds to the measured molecule, preventing the bridge formation, between the capture and the labeled antibody. And in these cases, you will get a false negative result. So just to keep in mind, it can be either a false positive or a false negative. So very much variable, these heterophile antibodies. Looking at our anti-animal antibodies, those will be the HAAs and the HAMAs. So we said that these are specific and they interact strongly with our assay antibodies. It's usually produced after acute or chronic known exposure to specific antigens. These antibodies are species specific and they have a higher avidity than the heterophile antibodies that we discussed previously. It's produced in response to animal antibodies, for example, animal-derived monoclonal antibodies injected for diagnostic or therapeutic purposes. We're thinking of Digibind, for example, also with vaccination or occupational exposure like vets or to pets. So looking at these two groups, the heterophiles and the anti-animal antibodies, most assays currently in use include reagents which will neutralize or block low concentration of interfering antibodies. So it will have minimal impact on the accuracy. But large amounts of your low affinity antibodies like the heterophiles or low concentration of antibodies with high binding affinity like the anti-animal antibodies can overwhelm the analytical system and lead to assay interference. And this error can be false high or false low results. So we spoke about the population incidence just now, but the actual method interference is estimated to be in the region of 0.5 to 2%. So it does occur. It's not that uncommon. We need to take note that the manufacturers are continuously improving assays, changing the incidence of interference, but it is still reported. Just reminding you of some case studies. So this was reported in 2020, a heterophile antibodies, false positive troponin, and acute coronary syndrome, a case report indicating a pitfall in clinical practice. So it is still occurring. Another case study, 2022, falsely positive HIV test due to interference by heterophile antibodies in a patient with mantle cell lymphoma treated with rituximab. So just on the topic of rituximab, it is a chimeric, so it's both murine and human. It's a monoclonal IgG kappa antibody that binds to CD20 on the B lymphocytes. And just to give you an idea, when the chemical pathologists are doing their serum electrophoresis and immunofixation, we will actually see a band, a monoclonal protein. So in this case, it's the IgG kappa, obviously, which we see on the immunofixation, and it can be mistaken for a monoclonal protein, and it is in that small size where you might diagnose an MGUS. So just keeping that in mind. Next category of interference is biotin interference, and the combination of the growing use of biotin strict evidence methodology on the one hand, and the rising popularity of biotin use on the other hand, has led to more frequent reports of erroneous diagnostic results, both false positive and false negative. So biotin is also known as vitamin B7 or vitamin H. It's actually Haar und Haut in German. It's available over the counter as a beauty supplement, and you can actually find doses of up to 10,000 micrograms per tablet very easily. So these pictures I actually got from the local market. So it is available. So 5 milligrams will be 5,000 micrograms in this case. And keeping in mind that the recommended daily allowance is in the region of 30 to 100 micrograms. So when we look at the first immunoassay interference report, it was described in a patient that was treated for multiple sclerosis. And in those patients, the dose is typically 300 milligrams per day. So that equates to 300,000 micrograms per day. So really massive doses that can be given with biotin. So if one looks at the literature, then the biotin in over-the-counter multivitamins in doses up to 1,000 micrograms has not been reported to cause immunoassay interference. But if you would digest doses more than 5,000 micrograms, it can result in significantly elevated blood concentrations that can interfere with commonly used biotin-related immunoassays. So before 2017, The FDA had received a report where a patient taking high levels of biotin died following low troponin test results when a troponin test subject to biotin interference was used. And in 2017 and 2019, the FDA issued a safety report to alert the public and healthcare workers of this potential harm. In 2020, the FDA set the biotin threshold requirement at blood concentration of 3510 nanograms per milliliter, and they said that at this level it will limit interference even with massive biotin doses, and the manufacturers are in process to meet these requirements. And one needs to realize if you are using a laboratory or a platform not using FDA certified methods, they will not comply with it. So there's always a danger of that happening. So should a patient be taking high doses, the following recommendations: samples should not be taken from patients receiving therapy with high biotin doses, more than 5,000 micrograms per day, until at least 8 hours following the last administration. And with massive doses, one should abstain for at least 72 hours. So keeping in mind that many of our lab tests are for acute management, like the troponins, and this will not be practical. So in those cases, it would be well advised to use an alternative method to do your troponin, for example. Just a quick idea of biotin interference. Once again, looking at our method design. If there's no interference, there's streptavidin sitting on the microparticles. It binds to the biotinylated antibodies. The analyte of interest competes with a labeled analyte for binding to the biotinylated antibody. Any residual specimen and unbound analyte that can now be labeled or endogenous is washed away, and the signal is inversely proportional to the concentration of the analyte. While if there is interference with excess biotin in the specimen, it will bind to the streptavidin binding sites. It will block the biotinylated antibody and analyte to bind to streptavidin, and you will get a false increase of the analyte. So this will be the case for free T4, for example. The non-competitive or the sandwich assay for TSH, with interference, you will see that the biotin in the patient sample will bind to streptavidin sites. It will prevent that sandwich formation between the capture antibody, the analyte, and the detection antibody, and it will lead to a false low result. So you can imagine in a patient with high doses of biotin, which interferes, the combination of high free T4 and free T3 measured with a competitive assay and a low TSH measured with a non-competitive assay can lead to an erroneous diagnosis of hyperthyroidism. And just to make it worse, if you are looking at thyroid antibodies on the same type of method, competitive assay for those antibodies, TPO, thyroglobulin antibody, TSH receptor antibody, you can also get false high values. So it can look very typical for a hyperthyroidism, but it is actually interference. Next category of interference, I want to speak about macroanalytes. So we know it is well described for prolactin, where we talk of macroprolactin or amylase, macroamylasemia. So in the case of macro TSH, the circulating monomeric TSH can bind to IgG antibodies. It can be polyclonal or monoclonal, and these antibodies are in vivo. This results in increased TSH, the hormone, which is biologically inactive, but it retains the ability to react with antibodies in the immunoassay. So it's immunologically active. You will get high values. It has a long circulation time, and in these cases, the biochemical profile mimics subclinical hypothyroidism, and it may lead to inappropriate thyroid hormone treatment. Just a quick reference to the high-dose hook effect. Usually we see this in tumor markers with very high concentration. So it will result in false negative or false low results. It's usually sandwich assays or the non-competitive assays. So in these cases, the excess antigen, in this case your tumor marker, saturates both the capture and the labeled antibodies, and there's no or little amount of the antibody antigen complex formed, leading to a false low result. And the way that we would detect this is with dilution studies. You will see that the value actually gets higher. Strep-evident antibodies, not so common, in the region of 0.4%. And the protein strep-evident used in assays is extracted from soil bacterium, the Streptomyces abedini. It's not really known how the immunization occurs. It's likely due to exposure during outdoor activities. It can mimic the interference caused by biotin. So for a non-competitive method, free T4, you will see a false decrease. And for the TSH non-competitive method, you will see a false decrease. And for a competitive method, a false increase. Ruthenium antibodies, also a rare case of interference. It is used in the industrial space, and the incidence not really known, but it has been reported in the literature. So when we think of possible solutions for suspected interference, so when the doctor calls the lab and says he does not believe this result, what can we do? To exclude heterophile antibodies, the anti-animal antibodies and rheumatoid factor, we can look at dilution. Just remember, it's not possible to dilute in the lab for free hormones like free T4 and free T3. Another possible solution is to use a heterophile blocking tube pre-treatment. So those HPT tubes will remove any heterophile antibodies in that sample. We can do a polyethylene glycol pre-treatment. We can do a rheumatoid factor assay. If it is very high, it might be the suspect. Or we can use an alternative method, especially if you are looking at biotin strep-evident or you want to exclude a specific species antibody. For your biotin, you need to take a careful medication history and also looking at alternative methods in that case. For the hook effect, the answer would be serial dilution. For macroanalytes, we will do our PEG pre-treatment or the specific method, a gel filtration chromatography. And then for ruthenium and strep-evident antibodies, one would look at an alternative method, and the antibodies for strep-evident can be removed with specific coated beads. This is not done very commonly, so you need to know what you are looking for. So getting back to our case studies, so the thyroid functions were done on the Abbott method. We know that it does not use biotin or strep-evident, so that was excluded. With dilution, the TSH recovery was not 100%, so we knew there was definitely something interfering. Rheumatoid factor negative, the HPT blocking tubes did not help us. The TSH did not recover. With the second method on the Roche, the TSH remained increased, and only with polyethylene glycol precipitation did we see that the TSH decreased to normal values from 20.2 to 0.4. And the interference by macro TSH was confirmed with a gel filtration chromatography. So that was the answer in this case. So just to conclude, interference is a real concern due to changing therapies. We are using monoclonal antibody therapies, biotin supplementation, and the interference, as you have seen, can be at any level of the assay design. It can induce false positive or false negative results. It may drive unnecessary investigations, inappropriate treatments, or misdiagnosis. We need to realize that interference in patient samples are not detected by standard quality control procedures, and the physicians should be very wary of discordant results or results not in keeping with clinical findings and communicate it to the laboratory timely. Thank you.
Thank you so much.
Thank you.
Yeah, at least, just always say that this is probably something that, as a clinician, you're not aware what's really happening. And we always know that the quality of the work will be that if you don't know what you're looking for, unfortunately, you can't question. So I think for me, that's give you quite a lot of insight into actually, when you interpret results, you could actually say, listen, but we have the guidelines. And why is the result? Because I think two of the things must really add up. I always say that I think in medicine that we shouldn't force things to work. If they don't fit in, means it's a problem. So you must look into it and find that's for me. Sounds great. I don't know, in CAMPAT, is it easy for everybody to understand it? Is it easy to figure out? Because I know most blood results just get signed out. And, I don't know whether people got insight into it or not, but we see it quite a lot.
It's perhaps easier with the hormones where you have an axis that you can evaluate. You have a pituitary hormone, you have an adrenal hormone, and you can correlate negative feedback or not. So that helps sometimes.
But if a GP sitting out there in the rural area in Soweto with no academic connections, how do you, on earth are you going to figure out that the results are abnormal actually? Doesn't make sense. What do you do?
If it doesn't make sense, he's most welcome to contact the lab. Pathologists are always willing to assist.
So the red flags, obviously, they need to look into the red flags, actually, what are they? And if you have to summarize in short term, in thyroid function, what would be the discordance normally in the red flags that the GP simply can look into?
Well, we spoke about analytical interference now, but sometimes you can get, for example, like a discordant result with a high TSH, high T4. It's not necessarily interference. You will need to look at other factors like drug therapy. Amiodarone may present like that. If he has a patient not taking his thyroxine regularly, the TSH remains high. In the morning before the test takes the thyroxine, you'll get a high T4. So it does need to correlate clinically, but at that point, if it does not make sense, contact the lab.
So basically what Karen is saying, that you need to have your basics right first, means you need to know if you're having hyperthyroidism, your TSH actually should be low and T4 should be very high. But if both happen to be very high, that means somehow you need to discuss with your CAMPAT pathologist and see whether the results make sense or whether you should pursue further testing or refer the patient to for second opinion in terms of getting endocrinologist, somebody who is a specialist in the area. And the same thing if you're having hypothyroidism, where sometimes you wanted your TSH to be high and T4 low, but now if you get everything low, that means if you get everything high, obviously high or low, then there's a problem. So I think the basic principle probably of understanding your tests probably is very important, I think. And I think for our next presentation, we're going to go for just ABC of thyroid hormone interpretations, ABC of full blood count, things just as simple, so that at least you have the basics, so that at least you could understand and put them together. Any comments? Want to say something?
Excellent presentation. Great overview. Really highlighting that the clinician queried because clinically didn't make sense. So it just highlights the importance of clinicians and pathologists working together, because we don't have the luxury of seeing what you see. So clinically, the symptoms are not making sense.
Yeah.
It's helpful.
Yeah, I agree. Okay, thank you
Very much.
for sharing.
Karen, do you by any chance have a register?
The other day, I thought because we already did log this for a second event, so I thought maybe we don't want to duplicate it.
Oh, okay, that makes sense.
So the event forms are
I don't think we can because it's the same.
Yeah, it's already logged. Yeah.
Okay.
Yes.
That can affect except but last week now.
Ek nie op analytical interference vlak nie, maar klinies staan geweldig baie medikasie wat
Oh, gehad van 'n dokter. I had a case of a gynae that in Wilkes complained about a patient. She was a German lady that she's got heavy menstrual bleeding. And then I did the PFA, and the PFA was abnormal, and I couldn't understand why platelets and everything was no previous bleeding history. Then I phoned the patient, make sure everything, but she's on really slim. She took her really slim, and it affected the platelet function. It had to be stopped. And then I went and read, it can affect because of the high, it's caffeine and even in the yeah, I think there's something there.
Pseudoephedrine.
Yeah, pseudoephedrine stuff, yeah.
Since that bad.
No.
Would be bad.
You must feel terrible if you're taking that.
Mm.
Well, sometimes we all that matters is the weight.
Positive methamphetamine drugs.
Yeah, I didn't hear anything back, so I still let it start.
Yeah, it's not easy. Yeah? The thing is that just if you want to pick up the problem is always great, but also getting the pathology on that side that will understand, you know. And I think you're right. We have to work together, and we kind of have to close that gap, you know.
If say the incidence is 0.5, then 1 in 200 patients.
We should have. My question: How much is the incident actually in South Africa? I always say, you know,
Population studies are so wide, and I don't think anybody's investigating.
South Africa
It's not
has.
hard if you think of how often we do thyroid test.
You can
On
expect
a
something.
No,
something.
we do. I think for it's a standard
Just
test.
tell the patient you're not taking your thyroxine regularly. Go back.
It's always easy, isn't it? Blames, yeah.
Yeah.
No, it's. I think it would be. I know in America. So one of my friends, he left. She went to US about 5-7 years ago, and she obviously internal medicine. So now she's focused on asthma and immunology. That's all she does. She doesn't see any other patient apart from that. And that obviously give you a lot of quite good insight if that's all that you deal with day, night. I think become easy to solve it. But in South Africa, I think because the ratio of clinician to patients is really, very low. It means one doctor for about almost close to 1 million people. It's in terms of pulmonology, I think currently maybe 1 million per one pulmonology, because if you how many pulmonology are active practicing out there. So now out of blue, you kind of have to deal with all these conditions, and you know, and even the labs themselves again, being histopathology part, they struggle to make a right diagnosis. Really, they struggle to make a right diagnosis of laptops. And again, so again, you can't focus on one thing. It's difficult, and I think because not enough, and people are not keen on the listen, this is not my area. Just chuckle it in. Yeah, but something that we do correctly anyway. But yeah.
So did this presentation record and broadcast?
Yes,
What notes?
it's done. No, she made a mistake. She switched the teams. Actually, what you're presenting is for Thursday. And Thursday is
The link is
the link. Yeah.
But it is captured and.
No, it's not. It's covered. I checked in and everything. So I didn't to speak to her about the links. We need to get it. So I really wanted to ask you guys, we need to contribute. Kind of how do we improve this thing better? The platform is here. How can we lift it up? You know, that's for me is very important. We need to obviously, I think this year was a lot of hiccups, but when I listen to presentations, sometimes when I drive, I do listen to the podcast. It's really lovely and clear. Okay, there's not so much interference. You don't hear voices or phones, whatever, which is quite very nice. So the presentation itself are not an issue, but the question, how do we make sure that actually the timing, are having issue with timing? We tend to step 4 or 5 minutes late, and perhaps we should actually get our pharmaceutical earlier
The end.
at the end, or 5 minutes earlier. 5 minutes earlier.
Yeah, because I mean, especially if the presentation's not going to go to an hour.
Yeah.
Yeah, we can make it rather
So we do 8:30. Okay.
Half
7:30. Yeah, I think that would be very nice, because I think I just wanted all of us to kind of get the thing. But obviously, I think once we get a scientific team, we'll have a discussion about that, because we wanted to incorporate a lot of presentation. Now we have this week we'll have 12 presentations. As I say, we're going to have legends presentation. Means we look at people that are legend in medicine, and most of them are really older. But it would be very nice to have recorded their voices presenting on a platform, you know, because at the end of the day, we'll be leaving this earth one day or another. But it would be nice to have something where, you know, former students can remember, recorded his presentation and that nicely. So I wanted to get quite a few key people, like, for example, I know on my side, we have people like Prof. Guy Richard, Mervyn Mer, Prof. Kerr, and Gettinger, and obviously Pete Vessels, that we always have learned. We always have listened to him from, I remember that was 2007 when you go to junior relationship already, he was always been there. I don't know how old is him. I haven't met him, but I spoke to him 2 weeks ago. He still sounds, the voice is like a young man.
He's 70, yeah.
Yeah, but it's amazing. You know, when you speak to him, it's like 10, 20 years ago. That's how he sounded. He's still like full of life. You know, when you ask him, it's not like, you know, he will call you now and so excited, try to explain to you a lot of stuff and everything.
I think every day he reads 2 journals.
Yeah. But that's what we wanted to. Yeah, so that's what we wanted to do, is to make sure that actually we have good presentation, but how do we inspire other physician, clinician out there saying, listen, medicine's not all that bad. You can love it, you can enjoy it, and you can also become a legend. You know, that's for me, that's why it's, you know, because medicine for me is beautiful, and that's the reality. And we must just make the best out of it and then see. So I spoke to him. He said you can come next year. You can give us lecture next year. Yeah, so maybe we'll do antiphospholipid or what we call atypical outlanders in the treatment of the venous thromboembolism. So things that are not yet known, then I think it will come and give us corner, or even do just ABC of the antiphospholipid syndrome, because that's a very difficult topics that we struggle on a daily, and the journals tend to complicate it and shouldn't.
But when you look at the results, you don't always know exactly what it means.
Yes.
I think everybody does the test, but you know, you gotta know what it actually means.
So we wanted to do something like that. So means you guys have to also play roles to make sure that if you know there are people out there that are great presenters, people that mean something so much in your department because you won't know, that you think that, you know, then bring their voices to be heard. So it shouldn't be all of us alone. Just to make sure that we have them there, and then actually even ourselves to prepare for those presentations. Like, I mean, if I get into a thing, then I always go to current presentation and you send it. That's okay, interference, because things don't fit in. Yeah. I think that's what it must be. And also it's fun. Congresses. You guys go to Congress. What? Okay.
There's a few. There's hemophilia one, the bone marrow ones.
Yeah, so we need to do hemophilias, the indication for bone marrow, for example, who should have it. And will be done in nice, I always say it should not be influenced by profitability or the labs or whatever is there. It should be like, this is bone marrow. Who do you indicate? Do everybody get bone marrow? What are the gray area? We should be getting exact area. Those are the things we don't know. We sometimes get all the bone marrow because we think that we're right, but we might be wrong. You know, and instead that's, you know, so we want someone. Yeah. Yeah. I mean, as I said before, we used to order 3 units of blood. Now we order 1. And then hoping that it goes, then you're hoping 1 will go up on prayers.
Yes, of course, I don't know if you've done the patient blood management course. It's a course that's available. I'm going to try and do it next year.
Okay. But then, yeah. So, and I think as time goes on, we would like to see people become a kind of narrow into one area and become your area, you know. For me, if I have my way, I want to do only one thing, or like for just do lung cancers. Finish. Maybe in 2-3 years' time. That's all I want to focus on, all my energy on it. And so
That would be great because I don't think there's anyone doing it.
no, there's not so many. Yeah, but if I go with it, then I need.
I mean, everyone deals with it.
Yeah, but I would like to go more into in depth into it and understand it more details. Wake up about it all the time. Yeah, and then see it, understand everything. So people can kind of pick up what they want to be. See. But for now, we can how many presentation attending? Are we full, Sanet?
Yes.
On the Wednesdays we are.
Yeah, the features are fine. So the 13th is Cornell, the 20th is yourself,
When?
on the 20th.
When it's me. Okay, good. I'm happy.
Okay.
You want to see yourself, and then you sound so surprised. Yes.
No, I'm ready.
was ready.
No, I just got too many.
It's 20 and 28, or we're gonna get something else for the 20, and
28,
we're having morning and evening.
28.
Yeah.
But 28, we're having the day.
Yeah.
I would like to present, but I'm just wanted to look at my program.
Thursday.
Yeah.
I'm just like concerned the way the year is. Just the two,
I'm just flying by here.
it's like crazy.
Yeah.
I mean, I think the last few weeks now.
But doesn't mean that's going to be better next year. It's actually getting worse.
In terms of what?
Everything. My life
Time.
especially. Yeah.
Yeah.
It's, you know, you move on.
You know, now it's coming.
Yeah, because that was coming.
Because we've worked. It's away.
It must come. It's on call on Thursday.
Holiday's over now.
It's on me.
Yes.
It was a very long day.
We always say that
Working.
when you come, always send a message. When you come, the scale will be outside ICU. No, we don't do that. Because the issue then, look, if you don't pick up weight, you don't have a holiday. And then check the GGT levels. If that's gone high, it means too much alcohol, then you must slow down. And you need to see the coronary right away. So,
Yeah, he escaped that before his holiday.
oh, why should I have someone die and who must do the work? No. We keep you alive until we're done with you. You're 75, and then we say, okay, it's fine. Yeah.
But is he back in South Africa now?
I think it's coming, arriving tomorrow.
Is it tomorrow?
If not today, I think.
Yeah.
Already.
I think he's back. Yeah. I think he's coming.
Because they're coming tomorrow to work.
Oh, he's coming tomorrow to work.
I think.
Oh, no, yeah. No, he's learning today. He's learning today, and then see.
Shame.
But Karen, thank you so much. This is really nice. Yeah. We're having a backlog presentation. We need your sport medicine presentation.
Okay.
Yeah, because we need that. It's really nice. And then we need the bloods. I don't know whether we should actually, because I was thinking, I'm trying to run over my head to see whether I could actually record my podcast during December. Just thinking. It's because next year I think we'll have congested, but I think maybe we just need to get all the legendary. We need to sit down and plan properly. So then, what do you think we must do? Get the team together
What do you
on 28. Like, how do we structure these Wednesday presentations? What are the topic that we need?
I suppose you have to figure out first, what do you want to do? Do you want certain groups of topics, or is it
Yeah.
just random as we've been going now, or?
No, I think let's ask the
Do we want
the
to ask?
hematologists, the hematology group. Maybe just like when they sit down, I think we have the three of you.
We could do like a theme for
Yeah.
once.
So you guys kind of you sit down and say, okay, this is what we want. So maybe we run that for a month,
Yeah.
and then we say, okay, maybe camp path, But we wanted like I think our presentation. I don't know whether I'm wrong, but I feel like should resonate if you do a classic presentation. Classic something.
I mean, something that doesn't change.
It doesn't change. It just goes with the time. Like position, as I say, if interpretation of code.com remain the way it is. It never changes, or anemia, whatever. So that we can't be able to catch specialists, registrars, and 5th and 6th year medical students. Because for me, they matter. So in 10 years' time, when I'm an old man, they're going to be managing me in the hospital. So I need to make sure that I have a good doctor who understands, who will follow up this thing, understand the basic, because that's where the problem we have in South Africa. We went for this congress in Dubai, was for the vaccine. And one of the things that was very interesting was there are two vaccines produced, the Pneumovax, which was produced by MSD. And they've been on the market for so long. Then Pfizer discovered there was a loophole on that. So what they did, they produced a Prevnar 7, which didn't work, then 13. So now out of blue, Pfizer produced Prevnar 20. And through CDC, they now push out MSD out completely. So now you could only get Prevnar 20 finished. There's 13 and 20 done. You don't need to have revaccination for pneumococcal. Now think about it, if it MSD, you don't need it because the Pneumovax is a T independent part, so you don't form memory. So now out of blue, they've been strung out for a number of years.
Big pharma is a powerful thing.
No, but the question is that for me, it was one thing, is that you have to evolve with the time. You have to evolve. Now, but I know that the MSD are now producing another vaccine because now Pfizer got the 20, they're producing 21. It's a time. Wow. Yes. It's like, wow. No, but this is how life it is. You know, when you
We don't have the stuff. We don't have the RSV. We don't have.
RSV is coming now. Yeah, it's
We
Pfizer.
don't have the adult varicella one is also.
No,
not
it's
available.
gone out and it is. So the point is that whenever you start something like this,
Things are simple.
it's great. But somebody out there is gonna try to see how do I actually make it better. So either we hurry up and make up properly, or sooner or later we'll have a platform that's better than ours. And all our duration times are gone. And that's how the world be. You always have to make sure that somebody will try to make you and all those. That's why we must get our scientific committees together and try to get it. So at this moment, we don't need a sponsor. I know AstraZeneca wanted to sponsor us, and then they say, obviously, they will help us distribute everything. But then, of course, once you've done that, you lose the flavor. Because sooner or later, they're going to ask, okay, can you do this for our drugs and everything? So I wanted us to keep it as pure as possible and then see when perhaps one day, if you can, then we get things like Investec and all the company. Once we have good subscribers, we get companies that are non-pharmaceutical so that we're not aligned to any of them. And then we make sure that we don't actually need to mention their product because again, we want to stay as neutral as possible so that we don't kind of become biased in terms of the knowledge.
It would be worthwhile to ask the target audience what they want. What does the students, what do they want? What would the specialists want?
I think they just wanted a simple presentation, you know, like ABC.
From what level? That's what we.
No, just you mix it. You mix it. The question that you could start, and then you bump it up. But we can do it like so simple. Let's just say full blood count. You can do that, and then of course most of the presentation will not change. They remain the way they are. You know what I mean? Like amyloid. How simple can you make amyloid? It's remain the way it is, and amyloid is not meant to be known by everybody. It's really a specialist kind of presentation. And then the labs, I think, and pushing understand each other. Hi, emergency. Hello. Okay, 10 minutes. Yeah. But anyway, you guys figure it out and then see.
Thank you, everyone.
Thank you. I appreciate it.